Hello, good afternoon. My name is Tze-Ern. Thank you all for being here today. My topic is on bipolar medication and pregnancy. And to begin that, I will say that I believe the CPGs, the whole point of them is to summarize existing scientific evidence and translate them into guidelines to guide us in our day-to-day clinical practice. So because of that, I'm going to take the next 10 minutes to share with you two very common clinical scenarios in this respect. And I will begin by saying that I think bipolar medication and pregnancy is a little bit like Goldilocks and the Three Bears, because it's entirely possible to have too much of this problem or too much of another problem, and what we need to strive for is a balance in between. So to bring us to our first scenario, that's when our bipolar patient, a young female bipolar patient, comes in and says, "Hi doctor, I'm on bipolar medication and I want to have a baby. Is there going to be a problem with that?" Unfortunately, the answer to some extent is there could be, because a lot of bipolar medications do reduce female fertility. They don't really do much things to male fertility, but female fertility is the one that we're usually worried about. A lot of these medications do cause hyperprolactinemia, which is not really good for fertility, and some of the atypical antipsychotics especially may cause this. Among the mood stabilizers, sodium valproate is actually one that is pretty much a major culprit here, because it does cause oligomenorrhea. It interferes with the ovulation cycle, and it also may cause hyperandrogenism. Neither of these things is very good for female fertility. But on the other hand, you have this situation whereby perhaps a young female bipolar patient does not want to conceive. She also needs some advice, because if she's taking OCPs, oral contraceptive pills, certain mood stabilizers may interfere with those, such as carbamazepine and lamotrigine. And this is one reason why I say this is like the Goldilocks thing, because on one hand, you could have a patient who wants to conceive but can't because of medications. On the other hand, you may have someone who's eager to avoid being pregnant, but they conceive because the OCPs aren't working as well as they should. So this leads us to our second scenario, which I'll spend a bit more time on. "Doctor, I'm on bipolar medication and I just discovered I'm 2 months pregnant." Very commonly, what we see is that somebody misses their menses and they go for a UPT, a urine pregnancy test, and they find that it's positive, and by that time they are just about maybe 2 months pregnant. This actually happens quite commonly, because I believe about half of the pregnancies in Singapore are somewhat unplanned, have some element of oops to it. So this actually occurs fairly commonly in real life. When this happens, to some extent, there will be crossing of fingers and hoping that nothing has already gone wrong, depending on what medication the patient is on. Sodium valproate, again, is a prime culprit in this area. It can cause neural tube defects, and that's when the dural sac it prolapses out of the body where it should not be. Commonly, this manifests as spina bifida. It can also cause other very scary manifestations like anencephaly and encephalocele, which, if you can imagine, the mother is going to be an emotionally fragile patient to begin with. And if a baby turns out like this, I mean, for example, anencephaly is not really compatible with life. If that happens to her, it's not going to be very good for her mental health either. But to put things in perspective, neural tube defects, which is what this type of growth problems are classified under, it's not as if they are a done deal in everyone who is taking sodium valproate. Actually, even in ladies who are taking valproate, the incidence is only about 1 to 2%. I say only because 1 to 2 sounds like a small number, but if it happens to someone, then to them it's 100%. They've got it for sure. But still, if you step back and look at the big picture, incidence is 1 to 2%, which is roughly double the baseline incidence of such things. Even if neural tube defects, NTDs, don't happen, the other thing that could happen to the baby is fetal valproate syndrome. And this one can come as a bit of a surprise because it may not be detectable before delivery. What happens in fetal valproate syndrome is that you get a child with a characteristic facies. This picture does show some of these characteristics. It's not as obvious as, for example, Down syndrome, but yes, it is. Okay. If you look at this child, you will see that here, the ridge, where there would normally be a ridge, is actually very flat. The nose is very broad. It's a very shallow philtrum, and the upper lip is very thin. So these are characteristic facial manifestations of a baby with FVS, fetal valproate syndrome. And unfortunately, it often comes with some form of growth developmental issues as well. There may be a chance of this child being mentally retarded or having some learning disabilities along the way. This, unfortunately, again occurs pretty much more commonly than neurotube defects. FVS may occur in as much as 50% to 70%, but to varying extents. Moving on from sodium valproate to lithium, which is again a common mood stabilizer, this one can cause Epstein's anomaly. I'm not a cardiologist, so this picture, I found one that actually explains a little bit about Epstein's anomaly. There is one thing that we can do to help prevent NCDs, but just NCDs, and which is periconceptional folate. So that is one very good reason for us to give folate to mothers who are expecting or women who are planning to get pregnant. So knowing this, some of us will find it easy to have a knee-jerk reflex in which if we see a bipolar patient who tells us that they're pregnant, then the first thing we do is tell them, stop all your medications at once. And while that sounds like the logical thing to do, actually in real life, according to studies, it may not actually be the great thing to do because pregnancy does not protect against bipolar relapse. And same as in non-pregnant women, if there is no medication for 9 months, over 50% of these patients will relapse. And this will put them at risk of mood problems, of being unable to cope with the pregnancy and with parenthood, of self-harm, and of inability to take care of the baby. The time of highest risk of this is actually the point of delivery and a few days after. And at this point in time, if they're not on medication, up to 70% of them may relapse. So all this scientific evidence tells us that it's not safe, it's not automatically the right thing to tell someone no medicines during pregnancy. So again, you have the Goldilocks situation. You have, continue medications and put the fetus at physical risk, or you stop the medications and the fetus will probably be physically fine, but you put the mom at high risk of relapse. So there is a fine line to be treaded in between. What we do, therefore, in this case is to try to find a balance. We aim to minimize harm and to maximize gain with our therapeutic options. One thing that we can do is, if the patient is on a mood stabilizer like valproate, we can consider replacing that with an antipsychotic. The newer ones, such as quetiapine, for example, or olanzapine, which is coincidentally by Eli Lilly, who sponsored our refreshments today, both of them are fairly good measures for replacing mood stabilizer during pregnancy. Another scenario is perhaps the patient is on a mood stabilizer and has to be on that particular mood stabilizer for her own mental health. What we can do in such a situation is to perhaps reduce the dose to the minimum therapeutic dose because fetal valproate syndrome, for example, that is actually dose dependent. So if you have a high dose of valproate, that puts the baby at higher risk of having this problem as opposed to a lower dose of valproate. Of course, through all this, co-management with ONG colleagues is very important because they will be the ones to scan the baby and to make sure that things are progressing okay. And the other thing is that we don't want a situation in which we fight with the ONGs, in which they tell the patient, these medicines are bad, stop them, and we tell the patient, no, you have to continue, and the patient gets really confused. So in order to minimize confusion in the patient, it's best to work together with the ONG. I do think, though, that the best way to prevent all this is to stop it from happening in the first place, and that's where psychoeducation comes in as an important measure. I think that's why we need to equip ourselves with this kind of information so that we can tell and teach our patients from early on what are the possible complications. And for example, to tell them, if you're going to plan to get pregnant and start a family, please come and discuss the matter with me first while you're still in the planning stages, not when you're already pregnant. So before you get pregnant, let's make sure that your mood is optimized, that you are on some safe medication at the lowest possible dose, and throughout pregnancy, you must come and see me regularly. So this picture reminds us once again that bipolar and pregnancy, when we are managing that, it really is a bit of a balancing act. And I think that the time involved in taking care of this, I actually do think it's best done by perinatal psychiatrists. And coming from KK, I will have to tell you that I think KK is a pretty decent place to have these patients treated. And also NUH is another place where they do good work for such patient populations. Having said that, though, I think that there will be some patients who come to see you before they get to us. And that's the whole purpose of the CPG, to help to equip you with this information so that now, knowing what you know from today's lecture and from the CPG, we can strive for a balance that is just right for our patients. Thank you.